This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on cervical artificial disc replacement, which basically means you've had a herniated disc in your neck and we take out the disc herniation and put in a prosthesis or a mobile device that allows motion. It's an artificial disc replacement. It's like a joint replacement for a hip or a knee. It's just done for the disc in your neck so it preserves motion, which as compared to a fusion, which stops the motion, the downside to a fusion is by stopping the motion of that disc, it can put more stress on the other discs, which may accelerate the natural wear and tear that's happening at the other discs. So an artificial disc replacement preserves the motion, which hopefully puts less stress on the other levels and helps preserve those for the long haul. A fusion is the number one surgery done all over the world because it treats everything. It makes more room for the nerve and it stops the motion, which most reliably treats a nerve, especially if you have weakness or spinal cord compression. So fusions are still the number one surgery done all over the world, but artificial disc replacements have a huge role in treating people with neck pain and nerve issues because it preserves the motion. It allows us to still take all the pressure off the nerve and off the spinal cord and preserve the motion, which puts less stress on the other levels. Yes, it also helps people functionally have a little bit more motion in their neck, but that's not the primary reason because most people with a 1 or 2 level neck fusion don't really notice a loss of motion. The primary reason is not that you have more motion to your neck, which is what most patients think. It's actually more biomechanically, segmentally in your spine. By preserving motion of that disc, it puts less stress on the other discs, so decreases the wear and tear at the other discs. And so it's not something people really feel or appreciate, but it certainly can make a difference in the long haul, especially if you need surgery when you're 30, 40, 50 years old, and you still got another 40 or 50 years to live. We want to save as much motion as possible to preserve those other discs so that hopefully you don't have to have another surgery. An artificial disc replacement is typically done for disc herniation, and the disc herniation is putting pressure on the nerve, which usually goes down the arm, which can cause pain, numbness, weakness down either arm or both. It can also, the disc herniation can put pressure on your spinal cord, which can cause an electric type of shocking pain up and down your spine and make it risky of being paralyzed or having a spinal cord injury if you don't have the surgery and take the pressure off the spinal cord. And the surgery basically entails us going in from the front, which is a very minimally invasive type surgery. We don't really disturb the muscles. Your spine is literally right under your throat. It's surprisingly close to the front of your neck. People think the spine's in the back of your neck, but no, it's pretty much right in the middle. And in fact, you have more muscles in the back. So a lot of times the surgeries we do from the back hurt more because we disturb the muscles more. Going in the front, we really don't disturb the muscles, and therefore the surgery really doesn't hurt much. And it's a pretty minimally invasive surgery because it does not disturb the muscles, so it preserves long-term function of the muscles. And that's really what minimally invasive means. It means save the muscles so the muscles can function long-term. So we do the approach. It's about a 1 or 2 inch incision on the front of your neck. We usually try and pick up a line in somebody's neck so that it's more cosmetic. And we do the approach, put the retractor in, move the throat to the side. And then the surgery, we put 2 stabilizing pins in the bone, which distract the bones open, which allow us to get to the disc herniation and take the pressure off the spinal cord and the nerves much less invasive and less traumatically because we've distracted the space open, which buys us some room. And it also stabilizes the segment. And then we use a microscope, and under the microscope, we remove the disc herniation, thereby taking the pressure off the nerve and or the spinal cord. And it's a very safe surgery because we don't really have to touch the neural elements. They're behind us. So we can take all the disc and the bone spurs out from the front without really having to touch the spinal cord or the nerves. There's always a risk with any surgery of neurologic injury, weakness, paralysis, numbness, worse pain. But overall, those are very, very rare with this surgery. It's a pretty straightforward, safe surgery. Once we've taken all the pressure off the nerve and off the spinal cord, then we're going to replace the disc space with something. With a fusion, you basically put bone in there, or plastic or metal, but it's basically a bony type of device. With an artificial disc replacement, we put the prosthesis in. And that typically has metal and metal. The metal sticks up into the bone. It gets the fixation into the bone, into the vertebra. And then a piece of plastic in the middle, or some type of mobile component in the middle that allows the 2 pieces of metal to move in relation to each other, which allows the vertebra to continue to move in relation to each other. which is what the disc typically does. The disc usually stays in between the vertebra and allows for the stability and the motion between the vertebra. That's what the disc does. So an artificial disc replacement is trying to reproduce that. It's got to be fixated into the bone so that it doesn't move, and then it provides stability, but it's got to allow some motion to preserve the natural motion and to save some of the stress onto the other levels. So there's a lot of different devices out. There's 3 that are really approved to be used in America today. They're all pretty similar. The results of all of them have been shown to be relatively similar. There's subtleties to each one, which is why we use one over the other for different cases and for different reasons. So the surgery usually takes about an hour and a half to 2 hours, and it all depends on the complexity of the case, but generally they're pretty straightforward. And after the surgery, the first thing we need from a fixation standpoint is we need the bone, the vertebra, to grow into the metal to really stabilize it. Now, when we put the prosthesis in, it's strong, and the natural ligaments that are still intact provide a lot of inherent stability. We don't take the whole disc out. We take about 80% of it. There's still the ligament on the side of the disc we leave intact, and that provides a natural check rein of stability to provide initial stabilization of the disc space. Also, we've distracted the disc open with those metal pins when we do the surgery, and that by that distraction, spreading the vertebra apart, putting the prosthesis in is under some natural tension and compression and stability because of the distraction that we put into the system. So this metal fixation into the bone typically takes about 6 weeks to 3 months. So you want to be a little bit safe and don't push it too hard. Certainly don't hit anybody with your head, and don't go back to being a defensive back in your rec league tackle football league and hit anybody with your head, because the prosthesis can loosen and can dislodge. And if the thing goes out the front, it can irritate your throat or make a hole in your throat, your esophagus, or it can go out the back and hit your spinal cord. So there's still risk with the surgery, but overall the implant we put in there is very, very stable right away and has good inherent stability, but it can take up to 3 months for the bony ingrowth to really lock this thing into place. Artificial discs have been tested in the lab and have been shown to last for greater than 100 years. And so it'll outlive the patients so long as we don't have some amazing discovery in the next 20, 30 years about prolonging life. And it can always wear out. The piece of plastic can wear out, just like a total hip or total knee. They can wear out. But the loading forces in the neck are so much less than in the hip and the knee, which you walk on every day, that these artificial discs have been shown to last for greater than 100 years. So it should outlive the patient. If it does wear out, well, sometimes we could change it out for a new artificial disc, or we could always convert it to a fusion. The fusion is always the backup plan. If something goes wrong at the time of the surgery, or immediately after, or 5-10 years down the road, the backup plan is typically to do a fusion, which typically can be done very safely. So right after the surgery, this surgery can either be done as an outpatient or people stay overnight. Either way, it's a very short recovery process, and most people are ready to go home pretty soon. We typically put a drain in just to drain out any fluid that's collected, but after 4 to 6 hours, if there's no drainage out of the drain, then we just pull it out, and that doesn't hurt. It's a very small drain. It's kind of like taking tape off or a Band-Aid off somebody. And what people can experience after the surgery, most people after these approaches from the front with the fusion or the artificial disc replacement, swallowing can be difficult. And that's because we've moved the throat to the side. And there will be inflammation and irritation of your throat. And also the intubation irritates people's throats. So expect to have some swallowing issues. Generally, those resolve within a day or two, but there's always a risk of it being permanent. But generally, it resolves after a couple days. And what you want to do is just start off with liquids, make sure you tolerate those, and then soft foods, purees, smoothies, yogurt, oatmeal, bananas, and then progress your way up till generally after about a week, most people are eating their normal food. The other thing that people can experience is muscle spasms. I'd say about 30 to 40% of people get muscle spasms, and it's because your body has undergone a surgical procedure, which is still a traumatic event for the body. The body doesn't know what happened. All it knows is somebody was probing around and doing work on the muscles and on the spine, and so the muscles will lock down and go into spasm and get tight to try and stop you from whatever you're doing. The body knows something wrong just happened. There's something invasive just happened, and the muscles basically spaz out. They lock down to tell you, stop whatever you're doing and let me heal. Give me some time to heal. So that muscle spasm happens in about 30 to 40% of people. It's usually very manageable. We treat it with pain medications such as narcotics, muscle relaxants. If the pain is really severe, then sometimes we'll use prednisone or an anti-inflammatory steroid. The narcotic use, obviously, there's a risk of long-term narcotic use with addiction and all sorts of other issues. But generally, narcotics work well for short-term traumatic events like surgery or a broken arm or something like that. And taking narcotic pain medication for 2 to 6 weeks is typically very safe, and it can help you to recover from the surgery in a reasonable way where you're still able to get up and move and go to the bathroom and do typical activities, daily living, by controlling the pain to allow you to do those things. So basically with the narcotic pain medication, we tell people plan on taking it and take it for at least 3 to 5 days, especially if you have pain, don't hesitate to take it. Take it. That's what it's made for. But at the same time, if you're taking it every 6 hours and you're not having pain, well, then back off. Take it every 8 hours, then every 12 hours, then once a day, until typically when I see people back 2 weeks after the surgery, most people are not taking narcotic medication 2 weeks after an artificial disc replacement. Some still do. A lot of that depends on were they taking the narcotic medication before the surgery. If they were, they're more likely to take longer to wean off it. But we typically plan on weaning people off the narcotic medication 2 to 6 weeks after the surgery. You can take anti-inflammatories after an artificial disc replacement, Advil, ibuprofen, naproxen, Aleve. The bony on-growth that occurs is pretty minimal and hard to stop. And so taking anti-inflammatories is very safe and reasonable. With fusions, we prefer not to take the anti-inflammatories for several months because the bone's got to grow all the way across the disc space. It's got to grow from one vertebra to the other, which is harder to get. Then with the artificial disc, the bone just has to grow to the prosthesis, which it's a butting up against, and so it's much easier to happen, which means you can take anti-inflammatories. So those first 2 weeks after the surgery, what it looks like is I basically tell people to take 2 weeks off of your life. Don't plan on having to do anything. You deserve a 2-week vacation. You've had spine surgery. Even though it's pretty small surgery, it's pretty sexy. With an artificial disc, it's going to move. We do it as an outpatient or you go home the next day, but still plan on taking 2 weeks off. That's the reasonable, normal human thing to do where you don't have any appointments, no meetings, no driving, nothing expected of you. Now, most people, after 3 to 5 days, they're working from home because you can walk and talk and do the internet right away. So people, Americans, we're so crazy. We'll start working right away just because we want to. But plan on taking 2 weeks off where you have the flexibility that if you are having muscle spasms or pain or swallowing issues, that you don't have to work. And now plan on 2 weeks, but after a week, if you're feeling good, fine, you can go back to work. We also say no driving for 2 weeks. We want those muscles to heal and to settle down. We give people a neck collar or brace to go home with after the surgery, and that's just to let your muscles have a break, take the pressure off the weight of your head, let the soft tissues heal. But people don't need to wear the brace all the time. They can take it off to sleep. They can take it off to eat. You can pretty much take it off anytime you want. But generally wear it if you're up and about and outside of the house. It'll keep people away from you. They'll know that you had surgery or something, and they'll leave you alone and not smack you in the head or anything. Now, you can ride in a car. Somebody else can drive you. You can take Uber. You can go out to eat. You can go to a movie, and you can go back to work if you want to, but plan on taking those 2 weeks off, and then if you feel better, you can go back sooner. Now, the dressing, we put a sterile dressing on in the operating room, and we prefer to just leave that intact for 7 days. And if you have any question or you're not sure, just leave it on for the whole time. We see people back 2 weeks after the surgery, at which time, if it's still on, we'll take it off then. We don't change the dressing a lot. We don't want to change it. Every time you change dressings, you can introduce bacteria. We prefer just to put the dressing on in the operating room and leave it on, leave it sealed, and then we'll check it in 2 weeks. But you can take it off after 7 days. If it starts to irritate you, anything like that, take it off after 7 days. Then you can shower and start to get the wound wet. So the wound itself, we actually close the wound with buried absorbable sutures. There's nothing to take out, but those sutures seal the skin, and then they will dissolve over a couple months, and they're buried, and you won't even see them or feel them. We also put glue on top of the wound, and then we put the steri strips on top of that, and then the dressing on top of that. So the point is there's 4 levels of protection. So it's sealed. We're overly cautious. We seal it as much as possible so that we don't have to worry about it draining or getting infected or anything like that. So the dressing that's on top, we prefer to leave it intact for 7 days. And if you want to shower, you can take waterproof dressings and put them on top of it. And then when you're done with the shower, just take the waterproof dressings off and leave the operative sterile dressing on and don't even change it. Now, if it gets wet or gets emaciated and kind of grungy, you can take it off. You can change it. You can put a new dressing on top because, like I said, there's still 3 layers of protection under that. So you can easily change it if you want to, or even if your skin is just getting irritated. So we see people back 2 weeks after the surgery. At that time, we're going to take a look at the wound and make sure everything looks okay. We're also going to take x-rays to see what the device looks like, to make sure it looks like it looked like at the end of the surgery. At the end of the surgery, we take x-rays, and we basically, at the 2-week follow-up, we want to compare the two. And all we're looking for is that it looks the same. Make sure that thing hasn't moved or settled or sunk into the bone. Those are all extremely rare, but if you've been around long enough, you've seen just about anything happen. So we want to take the x-rays to double check and see how things look. If the x-rays look good, generally then we get the person out of the neck brace, out of the collar. You don't need to wear that anymore. You can wean off it over the next several days. People can still use it. If your neck gets tired and the weight of your head gets tired, you can use it for up to even 6 weeks. But generally people are done with it at 2 weeks. We start the physical therapy 6 weeks after the surgery, typically in that range. For the first 6 weeks, we just want some of that bony on-growth to occur into the metal device up against the vertebra. We want that to happen over 6 weeks. And also, we just want the neuromuscular control of your neck to start waking up and to come around. Anytime you have surgery, it kind of throws the system off, where your brain says to fire these muscles, but they're not really coordinated. And it takes about 4 to 6 weeks for those muscles to start to wake up and the neuromuscular control to start to come back. That's all done automatically. You don't even think about it. Your muscles are firing all the time to protect your neck and to redistribute the forces. Well, that happens automatically, but if you have surgery or a traumatic event, it throws the system off. So it takes about 6 weeks for the muscles to wake up, that neuromuscular control to come around. Then we're ready to start the physical therapy. And the physical therapy really has 2 components. One is back strengthening, trunk stabilization exercises, your abdominal muscles and your back muscles, the front and the back. We want to train those to work in a coordinated fashion to keep your spine in a neutral position. And then the second component is the neck exercises, which are chest out posture exercises. Stick your chest out, let your shoulders fall back, let your head come back over the rest of your body. Everybody who sits slumped over, who has neck pain, sits slumped over. Well, the weight of your head juts out in front of your torso and it weighs more. And then it also strains the neck more and the muscles more and closes the holes for the nerves. So if you stick your chest out, let your shoulders fall back, your head comes back over your body, it opens the holes for the nerves, decreases the effective weight of the head, relaxes the muscles. So the whole exercise program is designed to do that. We don't do a lot of resistive exercises with the head. Sometimes people push on the head and push this way, push that way. You see some crazy exercise in the gym where some big guy's got a rope tied around his head and he's lifting up cement blocks with his head. We don't do any of that. That's more likely to hurt yourself. We go for work on the muscles around the neck to strengthen them, postural spine muscles to put your head in a better position, which anybody can do, and you can do them very soon after the surgery because they don't provoke pain. Typical results of the artificial disc replacement, most people feel better right away. We take the pressure off the nerve and most people can tell that right away. Some people will still have persistent nerve pain because the nerve is still inflamed and irritated. And a lot of that depends on how long did the patient have the pain before the surgery. If they had pain for 6 to 8 weeks, typically the pain goes away very quickly after the surgery, if not immediately. If you've had pain for 6 or 9 months, well, it's more likely going to take longer for the pain to settle down and the inflammation and that irritability of the nerve. Typical results from this surgery, most people's pain averages around a 7 out of 10 before the surgery, and it averages around a 2 out of 10 after the surgery. Which, if you're at a 7 and you go to a 2, well, obviously you're happy. That's a good reduction. But a 2 out of 10 means a lot of people can still have neck pain and issues, and 2 out of 10 is pretty subtle, pretty minimal. But a lot of that is a lot of us hold stress and tension in our neck muscles. So some of us, like myself, I've never had surgery. I get neck pain and muscle tightness from time to time. Well, that's just from wear and tear in life. And so our whole program of muscle strengthening exercises will help treat that 2 out of 10 pain for the rest of the life to keep the pain at bay and to keep you functional and keep everything working. And we have a whole non-operative and post-operative rehab program, including diet, meditation, massage, the exercises, everything that you can do to decrease the stress and tension in the muscles and to reinforce better muscle firing to put your head in a better position, which can help manage that long-term neck pain or issues and stiffness that most humans get. Long-term issues that we always look out for with artificial disc replacements, we mentioned that sometimes they can wear out. The piece of plastic, the mobile part of the disc can wear out with time. If that happens, we can replace it with another artificial disc, or we change it to a fusion, which are both very viable options and not very dangerous surgeries typically. There's also a risk of bone spurs forming. Because we're preserving the motion, bone spurs can form. Bone spurs or osteophytes form with any mobile joint in the body that has chronic inflammation from osteoarthritis or wear and tear. That's why your knuckles get bigger as you get older, because they get bone spurs. It's from just arthritis and chronic use over 70, 80 years. Same thing can happen with the disc and the facet joints in your neck with an artificial disc. Because we're preserving the motion, the bone spurs can form. And if they become symptomatic because they're pushing on the nerve or the spinal cord, well, sometimes we go in and take them out. And that's a reason why you may have to have another surgery after an artificial disc replacement in the neck. And the other component is that facet joint. For every disc in the front, you have 2 facet joints in the back. Now, the fusion treats everything. It treats the disc and the facet joints and the bone spurs, but it stops the motion. The artificial disc replacement saves the motion, but the facet joints can be a source of pain down the road if they develop arthritis. And that would be a reason why sometimes to change it to a fusion down the road. So like with every surgery, there's always potential complications in the surgery, immediately post-operative and long-term. But overall, cervical artificial disc replacements have been a great surgery that most people have had really good success with by getting rid of their nerve pain, taking the pressure off their spinal cord, preserving the motion, and overall returning them to their life and to the activities they like to do. If we can be of any help with any further questions, please reach out anytime. Bye-bye.